7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision and only your decision on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096. The opinions expressed on the following sponsored program are strictly those of the host, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors. Ant2.tv presents You and Your Doctor, teaching you to live a longer and healthier life. Proudly sponsored by All County Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Hello, South Florida and beyond, and welcome to the You and Your Doctor Show, Living a Longer and Healthier Life. Tuesday, May 1st edition, 2018. So really glad to have you across South Florida and, like I said, beyond, globally as well. So we're going to be talking tonight a little bit about gastroenterology. As far as we can get, we have one guest, a great GI right here from the Boca Raton area. Is actually, I'll ask him when he's on the air. And, he's 28 years experience in this area. So you can also catch us on Facebook Live, but I'm going to get right into it and tell you a little bit more about that later. Dr. Robert Mellman's joining us. He's, like I said, a gastroenterologist or GI. Dr. Mellman, how are you doing this evening?
Doing very well, thank you.
Great, I can hear you loud and clear, so perfect. I want to get right into it. One of the questions I had for GI is something that's been in the news a lot lately. It's the acronym GERD, and I'm going to have you actually give us a definition of it, but I've seen it lately in the news a lot more than normal. So I wanted to ask you first, what is GERD and why are we hearing so much about it? Is there something going on in society that's bringing it out more than ever?
Yeah, probably all the aggravation and stress maybe contributing to it. Maybe all the political polarization, but all kidding aside, I myself have had reflux for over 30 years. It's an extremely common problem that affects millions of people. But gastroesophageal reflux disease is something that we do have to pay attention to and take very seriously because there are consequences that can occur down the road if you don't address the issues associated with it. But what it is there's two kinds of gastroesophageal reflux. There's the kind that we refer to as heartburn, where you get a hot, acid, burning feeling that's coming up into your esophagus. And there's also non-acidic reflux, which is other contents that can occur within your stomach that can also come back up into the chest. So you don't have to have acid to have reflux disease. And this can occur at any age. There are babies that have very severe reflux disease and people in their 80s and 90s who can have bad reflux and everything in between. So, in many, many cases, what we do know about it is that most people have what we call transient esophageal relaxation of the lower esophageal sphincter muscle in the bottom of the esophagus. And what that does is that causes spontaneous acid to come up. Now, every one of us has these transient relaxations of the lower esophageal sphincter muscle. It's just a question of who has it more often, and longer duration of those relaxations can contribute to acid coming up. And also, in some people, which is not uncommon, we have hiatal hernias, which is when the upper part of the stomach slides up through the diaphragm into the chest cavity and also affects that, in a sense, that barrier between the stomach and the esophagus and allows acid to come up into the esophagus. So what happens to people is, besides the uncomfortable feeling of that burning feeling you get into the chest, if people have it come all the way up the esophagus, you can have aspiration. It can cause a chronic cough. It can affect your dentition over time. It can also, over many years, lead to a narrowing or a stricture so that it's more difficult for food to go through. And we call that dysphagia when a person experiences symptoms of food getting trapped or stuck. So those are some of the things that can occur. And then something that you might have heard about is a entity called Barrett's esophagus. And in Barrett's esophagus, excuse me, one has a change in the lining, in the epithelial lining of the bottom of the esophagus, in which it's no longer what we call squamous epithelium, and it can change to a columnar or intestinalized epithelium. That lining can become malignant over time. Now, fortunately, the vast majority of people never develop esophageal cancer who have chronic esophagitis. So what we do is we look at people, and if, for example, if you take 1,000 people that have reflux disease, about 20% can develop Barrett's esophagus or this change in the lining due to chronic reflux. But only 1 or 2% of those people who develop Barrett's will develop esophageal cancer. So the vast majority of people, even if they do have chronic reflux, will never develop cancer. But nevertheless, doing endoscopies, we have protocols in which we can monitor and follow people to help prevent, the development of cancer, and we have techniques of getting rid of Barrett's esophagus. But, esophageal reflux disease is a very, very common problem and affects many, many people. But fortunately, with the effectiveness of the medication that we have now, we can handle, the vast majority of cases medically with medication as well as other, little modalities we can use to help prevent reflux without having to get involved in surgery. But surgery actually is an option in a very small number of people who have severe symptoms that cannot be alleviated with just medication.
Well, thank you. I don't know where anywhere in the world anyone would find a better definition for GERD, so that is just fantastic. Thank you for explaining that, and you talked a little bit about the symptoms as well. Now, one of the questions I had for you, I think we've all, like you said, probably had acid reflux disease, the symptoms once or twice at least in our lives. In fact, there's a statistic I want to share a little later. I got to grab it. But I wanted to ask you, being a GI, do you hear about GERD happening more during the day or at night, or does the time of the day matter at all?
You can get reflux any time of the day or night, but it's a great question you asked, and I'll tell you why. Because you can have reflux while you're sleeping. And so if you have reflux while you're sleeping and it's not strong enough to wake you up, the damage is occurring, while you're sleeping at night. That's why some people say, you know what, I wake up in the morning and, I have like kind of a hoarseness to my voice or a raspiness in my throat, or I have like a bad taste in my mouth, foul taste. And so one may not realize that they're actually refluxing during the night. A lot of patients go to the ear, nose, and throat doctor because their throat bothers them, or they've noticed a change in their voice, and they may take a look down with a laryngoscope, and they can look in the throat, and they may see just kind of a redness, to the what's called the aryepiglottic folds and vocal cord areas, and therefore they may tell the patient, you know what, you got what's called laryngopharyngeal reflux from acid reflux, and you need to go see the GI doctor and discuss the treatment. So the answer is you can get it daytime or nighttime. Obviously, if you're awake during the day, you're going to, experience symptoms. But people can get it at night as well, and sometimes a person can even be woken up with a mouthful of hot, acidy fluid in their mouth, and that also puts them at a little bit of risk of aspirating, where if you get a big mouthful of that fluid and you're lying flat, it's possible some of it could even end up going into your trachea or causing a chronic cough. So it's important to be aware of the different symptoms that can occur, daytime or nighttime, but one can have acid reflux anytime.
And so I'm going to generalize this a little bit. I've definitely been had that happen at night a few times in my adult life where it kind of comes up, and then the first thing I do is if I wake up from it, obviously, and I can't clear my throat, I go get a drink of water. Now, how come just like slamming water like at 2 a.m. when this happens, how come that won't just wash it back down and keep it down? How come it continues to come back up?
Well, if you do drink cold water, the answer is yes. You're diluting the acid. You are swallowing, so the peristaltic activity in the water pushes it down into your stomach. And you may get momentary relief, could be for a couple of minutes, could be for, 15, 20 minutes. But the stomach is always continually making acid 24/7. It never stops. So because you're still making acid and because fluid empties out of the stomach fairly quickly, it doesn't take long for acid to then start to build up and come back up into your chest again. And so, drinking water is fine for kind of that moment in time. But if you really want to alleviate those symptoms, you're going to have to take medication. And so one can resort to what they call H2 blockers, like Pepcid, Zantac, Tagamet, and so on. And those may be useful for some people who have mild disease. But if someone's having moderate or severe reflux, then we use the proton pump inhibitors, like omeprazole, which is Prilosec, and Nexium and Prevacid, and some of the others. And they're all relatively equal in terms of their effectiveness. Some of the medications may have a shorter onset of action or be mixed with sodium bicarbonate, so you get a little bit of a faster action of the medication. But nevertheless, all these medications are useful for people who have reflux. And then the length of time that it suppresses acid varies a little bit between the medications, and especially between, the H2 blockers and proton pump inhibitors. The proton pump inhibitors are really considered the mainstay of treatment for people with moderate or severe reflux. But you're right. You can use antacids, you could take Tums, you could take Mylanta or Maalox, and you will get some benefit, but it's going to be brief. And if you want to control it better, you're going to have to use the regular medication for it.
And we're here with Dr. Robert Mellman. He's a GI gastroenterologist right here in Boca Raton. 561-395-5204 is his office. Dr. Mellman, I haven't been over to your office, so share with the listeners, if you would, your address and where you're located in Boca Raton.
I'm at 1000 Northwest 9th Court, Suite 204. It's just around the corner from Boca Regional Hospital. You could walk over to the hospital from my office. And I've been privileged to be part of this medical community for the past 28 years. We really are fortunate to have such a wonderful medical community and hospital. I've had many, many great physicians that I've been able to work with over the years. And, I still love being in the game. I mean, when I got here in 1990, I was one of the young guys here, and now I'm one of the older guys, and it's kind of hard to believe how fast the time goes by. But I've helped a lot of people over the last 28 years, and I can consider it still to be a privilege to be able to help people.
Now, that's great, and thank you for everything you do in healthcare. And like you said, that is a great hospital, a great community right here. Actually, you're right down this street from the studio I'm on the air at right now. We do broadcast all over South Florida and beyond globally as well. But like I said, it's a great group of doctors there. And we've had about 200 doctors on this program in 2 years. So,
wow.
Yeah, it's been going pretty good. I'm a former reporter, and all of a sudden here we got a radio program with doctors. So really blessed to be bringing the latest and greatest in healthcare, to the masses. So, Dr. Mellman, I wanted to ask you a question. So, if we're having that acid reflux, that GERD, that's really becoming, affecting our quality of life, something that, like you said, like maybe Pepcid or Pepto-Bismol after 2 days or 1 day is still an issue. That's the time when we go to our primary care and say something, or can we go directly to a GI like yourself and say, hey, we got these symptoms, or I have these symptoms, and how can you help?
That's a good question. I think for the majority of people who have initial onset of symptoms, it's fine to go to your primary care doctor, and they will be knowledgeable enough to be able to treat those symptoms. But if someone is, let's say, beyond a certain age, let's say someone's over the age of 50 or 60, and all of a sudden has new symptoms, that's something to be more concerned about. The term that doctors like to use are alarm symptoms. If, for example, someone's having all of a sudden at the age of 60, new onset acid reflux, or they feel like they have trouble with swallowing, or they see that they have black stool or a change in their blood tests, then that's something that they should be referred to a gastroenterologist to look into further. But if someone, for example, let's say is 30 years old and, stress of a new job or, children, small children, and they're getting some acid reflux, that shouldn't be, and there's nothing else ominous going on, they can go to their primary care and be treated with medication, and the vast majority will improve and get better. When symptoms remain persistent, despite medication, despite, let's say, 8 weeks of using a proton pump inhibitor, if the symptoms still continue, then definitely the person should be referred to a gastroenterologist. And it's for some of the reasons we talked about before, because long-term there can be more issues, and even shorter term, when someone's complaining of, let's say, for example, a burning in the lower chest, it isn't always gastroesophageal reflux. You may look down with an endoscope and find out that there's an ulcer in the stomach, or there's erosive gastritis, or they are positive for H. pylori bacteria. So sometimes the correlation between the symptoms a person experiences and what you actually find when you look down with a scope doesn't always match up. And therefore, if someone has persistent symptoms, there may be other etiologies that you need to investigate.
Definitely. We're here with Dr. Robert Mellman. He's a GI right here in the Boca Raton community. Dr. Mellman, you mentioned scope. So is that an endoscope? And if so, second part of my question would be, is that something that is done in the hospital setting, in the office? And is the patient awake for that procedure? Or are they kind of put into a light sleep?
So, upper endoscopies, or, is when we use our instrument to be able to go down and look into the esophagus and the stomach and the duodenum. And, when I first started my training, which was back in the late 80s, we had fiber optic instruments at that time. And so you were looking through a little, area in the scope, and it was a very small field that you could actually visualize. And it wasn't that easy to get such a wonderful picture of what was going on. And then as the instrumentation has improved through the years with the new video equipment that we've had for a number of years now, the HD equipment is just so phenomenal at being able to look at and see in great detail what's happening in the upper GI tract. So the answer is, there are specific indications that one would follow. If the person or the patient coming in has a certain set of symptoms that would then warrant checking and taking a look and seeing what's going on to help define what is the problem, what's the severity of the problem, and that way you have a better idea of how to manage treatment. How do you select what you're going to do and for how long? Will make a big difference by getting that kind of information. So, and as far as the way the exam is conducted, most people take IV sedation with propofol, which is the medication that unfortunately Michael Jackson got in an inappropriate setting. But that's what we most commonly use is propofol. It's a very short-acting drug with a short half-life. So you give it in small increments during the examination, and then when you stop giving those little increments, people are usually wide awake within about 10 to 15 minutes. So it's a beautiful medication because it creates enough, sedation and sleepiness that you don't feel anything when you pass the scope through the back of the throat. Now, early on in my career, before propofol came around, which wasn't until the late 1990s, we were using a little Demerol or Versed, or we were just spraying the throat with some xylocaine spray, numbing the throat, patient stayed awake, and you would just look down and ask the patient to kind of think about something else, breathe through your nose, try to relax. And occasionally, and it's not very common, but occasionally you'll still get someone, even nowadays, who will say, you know what, I'm too nervous, I don't want to be put out, I want to stay awake, I'm scared about what happened to Joan Rivers, And you know what? I'll honor their wishes as long as they can be made comfortable enough just by numbing the back of the throat with some spray. But I can tell you that, and I've done probably more than 25,000 procedures, that I would say vast majority of the time, people have no problem at all when you do it using a small amount of propofol. They doze off, they're comfortable, and then when they wake up in recovery, they can't believe the exam was even done. So, and it's safe, and it's being monitored by an anesthesiologist or a nurse anesthetist. So you're being monitored for your oxygen, your blood pressure, your pulse. You're being monitored by EKG as well. So you're being watched very, very carefully. So if you say to me, is there any worrisome or downside to it or danger, I think, and I don't like to be cavalier, because I think any time you do anything to somebody, there's always some risk, but I think the risk is extremely small. And so if there's a proper indication for doing the procedure, one should not be fearful that something bad is going to happen to them.
That's great news, and we're here with Dr. Robert Mellman. He's a GI in this area for the last 28 years, right here in Boca Raton and at Boca Raton Regional Hospital as well. So that endoscope procedure is obviously done in the hospital setting then, correct?
No, we do them in the hospital, but we also do them in outpatient ambulatory surgical facilities, which is very nice because it's a lot easier to utilize the outpatient surgical facilities than inpatient. When you bring patients that are outpatients into the hospital, which sometimes is necessary, because let's say, for example, they have many comorbidities. They have heart failure, they're on dialysis, they've had, respiratory problems, then there are proper times where it shouldn't be done in an outpatient facility. It should be done at the hospital. For the vast majority of people, though, it's much easier to utilize the outpatient surgical facilities for doing these procedures. Also remember, when you go as an outpatient into an inpatient endo unit, you're being mixed as well with inpatients who may have more serious disease or illness or infectious diseases. And although the rooms are sterilized and kept very clean, during the course of the day, you don't have a complete, wipe down of the entire room, in between cases. So, and again, the infections are not an issue, but theoretically, is it better not to be mixed with people, who, let's say, are in the hospital for long periods of time and may have C. diff colitis or MRSA, staph infections? I think it's preferable not to do it in the hospital unless there's an indication why you want to do it in the hospital.
And we're here with Dr. Robert Mellman. He's board certified in internal medicine and gastroenterology. Numbers 561-395-5204. Located right here in Boca Raton, right across from Boca Regional Hospital, 1000 Northwest 9th Court in Boca Raton. And then also I saw a listing that you're able to communicate to people in English, Italian, and Spanish at your office?
Well, I have two girls that work in the office that are Italian, one of whom can speak Italian.
Wow.
Yes, and, I trained at Jacobi Hospital in the Bronx, which was part of Albert Einstein. So having seen many Hispanic patients, and I've seen many Hispanic patients through the years, most people come in and they have someone in the family who could do interpretation, but I can understand, listening to people who speak Spanish, and I know a little bit, to be able to communicate back. But currently in my office, I do not have anyone who actually is a fluent Spanish-speaking person, but I would say for the vast majority of people, it's really not an issue. And I've had many patients from, Brazil, South America, from the islands, and many other places where communication I have not found to be an issue with the patients. And I've had, wonderful relationships with people of all different cultures.
Yeah, well, 28 years experience, you probably figured out just about everything that needs to be figured out in a doctor's office. Hey, Dr. Mellman, I just want to give a quick shout-out. We're down to our last minute. Ralph DeSerbo, he's one of my biggest listeners. He used to be at Delray Medical Center. Now I work with him.
Ralph's a great guy.
Yeah, he listened. He wanted to say hello and just, and just a shout out. Will you please come back onto the program, though? I want to talk to you someday in the future about colorectal cancer, so I'll send you some dates and
Absolutely.
We'll have you back on.
Let me know, and I'm more than happy to participate. You guys are doing a great job, and the community appreciates it.
Thank you. You were great, and we'll see you next time on the You and Your Doctor show.
Very good. Good night.
Thank you.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision, and only your decision, on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096. You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888. All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision, and only your decision, on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096. The opinions expressed on the following sponsored program are strictly those of the host, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors. AMP2.TV presents Tell Us Your Business.